I remember having a meeting with the president of the American Diabetes Association. I remember them saying, we don't want people with diabetes to think that they have to eat any differently than anyone else. We just want them to use more medicine. I was training at an early age, like with the weights and really into all that stuff. And my cousins were importing natural products or dietary supplements from Europe. I mean, I just won a national qualifier in bodybuilding. It just looked incredible, felt horrible. I was having, blood sugar problems. I was getting skin rashes. I mean, I just was not feeling well for, a 22-year-old. So since the beginning of recorded medical history, the most valuable herb in every culture was an adaptogen.
All right, everybody. Welcome back to the Off-Label Podcast. Today's guest is somebody whose work I've followed for a number of years now. Dr. Jim LaValle is a clinical pharmacist. He's a board-certified clinical nutritionist, and he's the founder of LaValle Metabolic Institute and Metabolic Code. He's authored over 20 books, trained thousands of healthcare professionals, and has been named the National Clinician of the Year by the Natural Products Association. He's worked in the past with elite athletes across the MLB, NHL, NBA, and Pro Football Hall of Fame, and is now the Chief Science Officer for Lifetime's Longevity and Performance Program. This show is called Off-Label because we go beyond conventional approaches to find out what actually works, and Jim has been doing that for decades, blending natural science with innovative strategy to get real results. So today we'll go over some things like peptide therapies and using labs and biomarkers to reverse metabolic dysfunction before it becomes a disease. So Jim, it's an honor to have you on, man.
It's great to be here.
Yeah, I actually, speaking of all of the books that you've written, I am about halfway through. It's quite a dense one, but I'm reading the Peptide Handbook. I know that's been a topic of discussion lately among a lot of people, so it's been really cool to actually see some clinical protocols with peptides.
Yep, exactly.
Well, let's just get started. I just want to ask you, I know your background initially was in pharmacy.
Right.
So I'm interested, how did you get into that in the first place? And then I guess if you were going back, what is your purpose in pharmacy right now?
Wow. That's a great way to start. It was interesting. You know why I picked pharmacy? Because I was sick so much as a kid, I went to the local pharmacist, and he was always really nice to me and gave me a little toy when I was getting my prescription filled like 8 times a year for antibiotics because of my chronic tonsil and sinus infections. Right. So I thought, this looks pretty cool. He's really nice. He gives out toys. I don't know. I got to be honest. I don't really know why I picked pharmacy. My mother worked in a pharmacy back when it had a soda stand and all that. I think it was in my genes, maybe. I don't know. I mean, so I will say one thing. When I got there, I got passionate about it. So I think it was a predetermined thing because at my university, we had a rich history of botanical medicine founded by John Uri Lloyd. We have the largest botanical medicine information library in the world in Cincinnati when I lived there. So I got very passionate about it quickly. We had to take things like, ethnobotany, and we had to take organic medicinal biochemistry, and we had to extract things from plants. So I don't know. Caught fire when I got there, and how's it play for me now? I got to be honest. I look at everything. It could be an emotion. It could be a plant. It could be a breathing technique. Everything changes molecular conformation. So that meaning the signals in your receptors change. And I was interested in what changes those signals.
That makes sense.
And I was very fortunate in my pharmacy training. We were in a top school in the country at the time, in pharmacy, and really got a great in-depth education on that.
I'm curious, do you think that was a pretty unique experience getting the botanical medicine background? Like, I'm just thinking of my experience in medical school today. I mean, I could play the conspiracy theorist cap and say that I didn't learn anything about botanical medicine, mainly because that's not a big moneymaker. Do you think that plays a role in the traditional education system right now?
I was at the tail end of it. To tell you the truth, Clay, I was at the tail end where we were, where we were taking pharmacognosy and had, a full year of organic medicinal biochemistry, right? So we were at the very tail end of that, and it kind of got away from it. Now you got, University of Mississippi's got the National Natural Products Research Group there. But to say it's a part of the normal curriculum, it isn't. When I taught at the University of Cincinnati, both in the College of Medicine and Pharmacy, I actually was fortunate. I could teach a course for 18 years called Survey of Natural Medicine. I could get fourth-year med students aware of, botanicals, their value, the evidence, the lack of evidence, the benefits, the risks, right? So I thought I was very fortunate to be kind of, in the 80s teaching that and publishing some of my earlier books and databases.
That's funny that you said that the University of Mississippi has that natural products place or
research.
Kind of,
yeah.
That's where I went for medical school. I've never heard of that before.
You didn't even know it.
No, I had no idea. So, and I wish I had back then because I started getting into all this.
It passively diffused into you. You don't even realize it.
I was just in the air, I guess.
Yeah, no, that's a nationally. I mean, they are really leaders in research on natural products, actually.
Yeah, that's crazy, and that's something that I really thought was a shame. We go through med school, and I ended up going into PM&R as a specialty, which nobody really knows about, but basically is kind of like more of a holistic type practice. You're looking at the whole person. You're trying to get them more functional, more able to do their activities of daily living. You can go into sports medicine. You can do all these things.
Right.
And I look back at my medical training in school, and I realized, like, man, a lot of my time was spent learning about chemotherapy drugs and all of these other, like, really expensive medications that only 1% of practitioners are really going to use, let alone come by and practice. And I'm just now I look back and I'm like, man, like, why weren't we talking about, utilizing L-theanine for anxiety or utilizing ashwagandha for bringing down cortisol? Like, all of these things that are potent and have been around for thousands of years and used by people in the past and have shown to work. And we're not learning that in the traditional system. We're just all pushing medications.
Yeah, and I think, some of that is it's still, and believe me, I've got a lot of respect for the traditional medical system because I still have taught in it and, incredible respect. But the issue is you're not thinking about theanine or ashwagandha because in traditional medicine, you don't have a problem like with your adrenals till you have Cushingoid or Cushing syndrome or Addison's, right? So we don't even think about that versus the thought of, can we keep you resilient so that never happens? And I think that's the problem that I know we've talked about this offline. That's where the real crux to this issue is that everybody's wanting to say change healthcare. I just think we need to add to healthcare.
Right.
Right. And I think that's where and it is tragic. I mean, we were teaching, it was interesting. One of the things that I did was I had my students on my drug-induced nutrient depletion. We had a handbook on that. And in fact, it's hanging on my wall over here. I would have my students take a drug, list all the side effects, then take that same drug, look at the nutrients are depleted, list the side effects of the nutrient depletion, and then I would make them transpose it. And I don't know why drug companies aren't more into this because you would wipe out, in my opinion, 70% of the adverse events.
Yeah, that's pretty crazy. When I was going through, that's all we thought too, is this drug is causing the side effects, the most popular one right now is like GLP-1s, reducing things like B12. Right. We're taught GLP-1s cause all of these side effects like paresthesia, whatever is the side effect of B12. We don't actually look one step further and kind of raise the veil. Yeah, that's pretty crazy. And when did that shift happen for you? Like when you were going through, let's just say, your pharmacy training, were you kind of, and I know you said you had the botanical medicine background and everything, but once you actually got out of the educational system into training, were you already thinking that way, or were you kind of in that traditional mindset for a little bit until you realized, maybe this isn't the correct way to go all the time?
Well, I was training at an early age, like with the weights and really into all that stuff. And my cousins were importing natural products or dietary supplements from Europe into the U.S. and selling them to physicians back in the 70s and 80s. And I got exposed to them. So it was in the back of my mind, but I got to be honest. What changed me, I just won a national qualifier in bodybuilding. I just looked incredible, felt horrible. I was having, blood sugar problems. I was getting skin rashes. I just was not feeling well for, a 22-year-old.
Yeah.
And I asked my cousins, hey, who can I go to? I really, nobody's really figuring this out. They're just giving me cortisone, powder, vanishing cream to put on my chest and to put on my legs. So they sent me to this, doc. I did what he said. He said, you have food sensitivities. I want you to get off of these foods. No more using honey or these muffins. This is how I want you to eat. They tested me for actually food sensitivities back then. Cleaned up my gut, worked on my gut health. This is 1982.
Wow.
And it turned me around. It was just this immediate change that I could not explain. I have to learn about this.
Right.
And I said, I've learned all this stuff on botanicals. Now I just need to understand how they both have value, right? Because they both have value. I mean, sometimes you need bioidentical hormones, you need prescriptive agents, you need compounded prescriptions, you need peptides, and sometimes it's not that, right? But that's what lit me on fire. And I only stayed in practice like a year of doing pharmacy. And I mean, it was important because, what got me into that was I was behind the counter at a pharmacy, a really rough neighborhood. I weighed about 260 back then. I was just like this big knot, big muscle. And they said, we're going to put him in the roughest neighborhood because nobody's going to rob him, right?
Right.
But a lady came up to me, gave me a prescription. It was a diabetes medication, and went around to shop. She was on a Medicaid card. Comes back to me. I look in her cart, and everything she chose was wrong. And I just asked her, can I show you around the store, which I was not supposed to do. Pharmacist's not supposed to leave to do that. But I didn't know. It was brand new. Well, she sent 12 of her friends in a very low-income area to me in the next 2 weeks to get the grocery store tour. That transferred into the largest food tagging system. We did that with Kroger. They developed a food tagging system for diabetes and heart-healthy foods, impacting millions of lives.
Wow.
That's what really was I'd say the transformational moment was saying, wow, you can just reach out and help one person and it can turn into millions.
Yeah, and it's interesting because I feel like you almost have to have a personal story that feeds into this whole kind of, for me, it's a new system of like functional and regenerative medicine, however you want to call it, integrative medicine. I know you've been around for a while now inside of that system, but I was no bodybuilding champion. I think the best thing I ever won in that era of my life was like a local beer pong tournament with my fraternity, which probably added to what I'm about to say. Yeah. I went for four years between 18 and 22, 23, and I would get strep throat. I mean, literally almost every single month, if not every other month. By the time I graduated college, I showed my ENT all of the diagnosis that I had of the 20 to 24 times that I had been actually tested positive for strep,
right,
given antibiotics and steroids and all of the shebang from some local, urgent care.
Right.
But at the time, I was 9% body fat. I mean, I was 20 years old. I felt like crap. I couldn't breathe out of my nose. I was convinced to get sinus surgery at 20, tonsillectomy at 21. 3 months after the tonsillectomy, got strep again, which they told me would never happen. And I'm looking at my, face down. My face was swollen, probably from, my diet and all the steroids. But I'm 9% body fat. So in my head, I'm like, I'm doing great. This is all just happening to me, and there's nothing I can do about it.
Right.
So I had that woe is me attitude for a long time, even until I got into medical school. COVID happened. I started the veil got lifted in the medical system a little bit for me, and I started doing these different things with my diet. I did a carnivore diet, which I don't push on anybody, and I don't currently do, but it was the ultimate elimination diet.
Probably for a while, right?
Yeah, it was a great elimination diet, and it took down all the inflammation so that I could kind of build back a better, healthier life. And then from then, I've just looked at the whole system differently than I did beforehand.
Yeah, that's that awakening, right? I mean, honestly, I look back at 40 years, and I kind of have all my books around me and all this stuff that I've done, and no, those aren't the bottles from my early practice days. They're a little early. That's a little older,
all right,
a little older than me, but they're good energy. It's good energy. But I just think that once you have it happen, and that's what I loved when we first chatted, is once you get the passion for this, man. I'm 65, and I just wake up every day looking for the next thing. It just doesn't stop. which is fantastic.
That's amazing, man.
Yeah, right on.
I'm curious. I know you're somebody who loves diving deep into lab results. Labs don't lie. If you're somebody, let's just say, because I'll just use myself as a personal example. I've always been somebody that likes to experiment on myself, especially if somebody asks me about a supplement and I've never done it before. Nothing crazy, but like started out with vitamin D and magnesium and
sure.
And so I'm kind of a supplement nerd, and I found the value in lab testing for deficiencies and actually targeting your supplementation. If you look at the way that you look at lab testing now, how does that differ from 10, 20 years ago when you were looking at it? Has anything changed, or do you kind of go by the same guidelines when you're recommending things to people?
Well, I mean, I think the nutrients haven't changed that much, other than some newer things. I mean, how I used to look at labs, this is high, this is low, this is trending high, this is trending low. Because even 20 years ago, when I wrote Cracking the Metabolic Code in 2002, which is 23 years ago, I was discussing trending lab analysis and insulin resistance and the relationships between cortisol, insulin, and thyroid hormone. I would say today I'm much more, I would just say, embedded in the fact that the body is a system of systems, that you're only as strong as your weakest organ. All systems are communicating with everything, and you have to get a full thought, a full look at the labs, and try to understand where is the orchestration point of the dysfunction. People like to call it the root cause. I'm more like a root causes guy. I think there's more than one thing going on. And so, I think that's what it's been for me is understanding connectivity. That's kind of how I developed the metabolic code, was writing an algorithm that's got a lot of connectivity, around 40,000 decisions in it. Versus just this is high, this is low. And I think that actually came out of just seeing 300 to 400 people a week doing this work for years and years and years, with physicians as partners, nurses as partners. And I was just kind of the guy, the weirdo guy walking in a room that could, look at a lab test and you say, this, boom, go. That was a little bit of that.
That's the kind of guy I'm trying to be, honestly. Cracking the Metabolic Code was 23 years ago now. Obviously, it was way before its time. I mean, I can imagine that there were probably some people that thought you were a quack back then when you started speaking like this, and now it's become mainstream, and you're kind of a hero in that sense, right? So
yeah.
But I am curious because there's been a lot more research that has come out since 2002. I think our medical knowledge doubles every 73 days.
Right.
Is there anything now that you look back and you're like, man, I either got that wrong or I should have been emphasizing this more, or what now do you focus on a little bit more than you did off the bat?
I would say the nervous system, autonomic nervous system, sympathetic, parasympathetic balance is probably, I talked about stress and cortisol and allostatic load, but really synchronicity, autonomic tone, I think is big. I wish I'd have emphasized it. Shoot, back then, there wasn't but 100 studies on the microbiome. And when you talked about, gut permeability, there might only have been 8 studies at that point, right? I mean, it just wasn't there. I think it's more, my new one's coming out. I mean, the new one's going to take us into the next 20 years because I'll probably have that same irrational thought of having to be, way out there instead of writing a bestseller.
Yeah.
It eventually became a bestseller, though, because as the industry came up, more and more people said buy it, right? So it did work out.
It's a work of art. At least you got to experience people loving it during your life. I feel like a lot of artists come out with something and they don't know that it's popular until after they're gone.
I got to tell you, I'm super, super blessed that I feel like as I got into this at an early age. One of the proudest books I ever wrote, I only wrote a chapter in it, was the book Diabetes and Cancer, Epidemiologic Links and Molecular Evidence. I mean, that, for me, was a defining moment of writing a medical textbook that literally, and I was talking about inflammatory cytokines and disruption in the insulin receptor and all that way back then. I'm trying to remember when that book was, 2008 or something. But that was amazing because it was a medical textbook. And we literally started that journey of medical science saying we are a systems of systems. This is how you develop a cancer cell. But I think all the information I really don't regret. I think I write to the best of my ability, for what I know today. And then I just hope to pile on a bunch of better knowledge, tomorrow, right?
Yeah.
But that was, I'll tell you what, that was probably the biggest thing on that Metabolic Code book is not enough appreciation. And we didn't know, nobody's talking about HRV back then, right?
No.
We just didn't know really what was going on, So, I mean, that was probably my biggest thing. And the new one will have plenty on that. Unfortunately, my first edit on it, it's an 850-page document.
Ooh.
So I think that book was 660 pages. I didn't think anybody was going to buy it.
Right.
But I didn't care because it was my opus. So this is opus 2. But I do have to get it down under 850 pages.
Is it Metabolic Code 2? Is that what it's going to be called?
No, it's probably going to be called, Rage Against Metaflammation. How to beat up on aging and, promote your longevity. And I think the big thing is on that is just getting people into practical advice too. Right now in the biohacking world, people are pumping so many things in and doing so much that I don't know that it's actually doing what they want it to do.
Right.
Yeah,
so. I agree. People are doing a lot of things without any data. And I was listening to a podcast the other day, as long as it's safe, it will be interesting once we start to get data on a lot of these quote unquote biohacker communities that are doing things that aren't going to be, publicly funded by some sort of company that wants to pump billions into it. So I'm interested where a lot of that goes, but I'm with you. Like a lot of this is just kind of chasing things that aren't really there.
Yeah.
I want to back up for a second because your son Christian actually sent me a picture of the diabetes and cancer book that you wrote, and
nice.
and I've been meaning to read it because I've been diving down deeper into that. I'm no cancer expert or anything, but it doesn't seem very controversial to me that you can make the stance that the vast majority of cancer cells dramatically prefer glucose over any other source of fuel, and the rest of our body can adapt very well to things like ketones and a ketogenic diet. And I've had to rotate multiple months throughout my residency at a very prestigious cancer facility here. And when I'm looking through the patients, I'm like, why is no one on a ketogenic diet? Like, I don't understand how is that controversial? Like, I can get, if... And
given ivermectin and fenbendazole, right? Like that you could go, okay, I get it.
I get it. In a traditional sense, I totally get why that. But whenever I ask the question, why is so-and-so not on a ketogenic diet? And then I get that look like the first 2 weeks of COVID when somebody was like, I don't want to take the vaccine. It's like, that's not the same level of weird. Like, I don't understand where the disconnect is.
Believe me, this was very frustrating for me because I was doing a ton of work in Cincinnati with a lot of cancer patients and still take on some. But it was obvious that, okay, the Warburg effect is cancer cells take in sugar at 50 times the rate of normal cell. You light up cancer cells by giving radio-labeled sugar water to people and doing a PET scan. Why don't we slow down the sugar going into the cell?
Right.
That makes sense. And that was that book, that Diabetes and Cancer. We mapped out all of the molecular steps and signaling steps that go to creating an immortal cell. And diabetes is in the middle of it. I mean, and so I could not agree with you more. We would put people on modified low-carb or ketogenic diets, and we would see great results because they were still doing their chemotherapy. I'm not saying, you just have to do a diet.
Yeah.
But what we know is, you have certain people doing insulin potentiated chemotherapy. Why are they doing that? To make that chemotherapy drug go into there quicker.
Yeah.
Or you're doing things to make the cancer cell sluggish, right? So that the chemotherapy can kill it better.
Right.
I don't know. I thought it was interesting. I'm with you, man. I've been on that train for a long time, and it's still, I remember having a meeting with the president of the American Diabetes Association, and this is a long time ago at Roche. So, I've done a lot of, industry stuff, and been all over. And I remember them saying, and I'm not going to say who it was because a long time ago, it's going to be any span of time, we don't want people with diabetes to think that they have to eat any differently than anyone else. We just want them to use more medicine. That was the statement that came. It was actually a board of the top endocrinologists, and myself and a NASA scientist were presenting why people with diabetes should take a specially formulated multivitamin, something with more magnesium, more chromium, omega-3 fatty acids, vitamin D, like all the obvious, right?
Yeah.
What we think today, but man, did I get shot down. Woo! That was going down in flames, man. They were attacking me.
I mean, you think of all the areas like that you can almost look back on. I mean, I know you're not that guy, but you could definitely look back and say, like, I told you so. Like, now we're starting to figure out a lot of these things. And one that's been, blown up recently because everybody is starting to realize it, or at least I hope. I know it's probably not as high as I think because of the circles that I'm in, but hormone replacement therapy is another one. The Women's Health Initiative in 2001 or whenever it was, and people are starting to realize how dramatic of an impact that had. I mean, we basically starved 20 million women out of having, life-altering hormone replacement care.
Even life lengthening, if you look at some of that data, it was life shortening when they did that recent review and discussion of all that data. So, boy, we started doing hormone replacement. Maureen Pelletier was my OB that worked with me at Good Samaritan Hospital. We actually started the Integrative Medicine Center at Good Sam Hospital in the early 90s. And she was the OB-GYN that was doing men and women's hormone replacement way back before it was cool. She wrote The Idiot's Guide to Menopause. Beautiful doc. I mean, incredible. And I got to look at it firsthand when she was doing hormones, the difference it made in people's lives. And I think you're right on. That's another great example of we just got it wrong.
Yeah. I think if there's one deficiency that the medical system has, it's humility. It's looking back and saying, we were actually pretty wrong about that one for the last 20 or so years.
Yeah, it doesn't do any good to put, look, I don't think it does any good to point fingers. Everybody's trying, in my opinion, it's like, I knew the guy, the PhD that developed the first MRI was in Cincinnati, right? He was like the guy.
Yeah.
It took 30 years to accept that an MRI was acceptable, right? and I just have to tell you, I live by this simple statement, new ideas don't get accepted, old people die.
Right.
So medicine changes slowly. In your generation, you're going to be a forward thinker, and you're going to take it forward just like I've tried to take it forward and will continue to take it forward. I do know one thing. There's a massive movement in the space related to longevity to incorporate all these therapies from the telemedicine perspective, from the in-office perspective. It's finally come of age. I mean, it's been around. I mean, Europe. I mean, I learned from homotoxicology docs that were talking about systems biology and writing books on it in the 60s. It's not like I was discovered something. I stand on the shoulders of the people that I learned from, right? As do you, right? It's all good.
Yeah, I feel like we're almost back in the era of like trying to get to space, right? I feel like longevity is now this huge gold rush of like everybody's trying to figure out the best biological aging clock and like the best supplement to take to actually extend aging. And we're comparing all of these mice studies, and some people say that it works and some people say that it doesn't. And we hear about all these new drugs that are coming out and all of these. I'm thinking of metformin was really hyped up, and then what's the one that Peter Attia loves?
Rifampin. I mean, not rifampin.
You know what I'm talking about? The transplant drug.
Yeah, rapamycin.
Rapamycin. Thank you. And
there's always rifampin. It's not rifampin. It's rapamycin. So, and the other one who was real hot was David Sinclair wrote all over metformin, and now he's on saying I'm not taking it anymore. It didn't do well. I'm not going to say I told you so, but we knew that metformin, if you need metformin because you're a diabetic, different story. But if you're taking it and you're healthy, there was some evidence that it created ragged mitochondria. And about a third of the people, it disrupts their diversity of their microbiome. It's some people that come new to this that are authorities. And this is not reflected directly in David Sinclair. I'm not saying this regarding him.
No, shout out to him for saying that he's not taking metformin anymore.
That's 100% true that he would back up on that one. That was great. But my point being is, if you're new to this field, everything sounds incredible. And what I've found is that and I know this because I've seen some some biohackers that, they're doing a lot, and you do their mitochondrial test, and their mitochondria are really banged up. So I think it's that there isn't going to be a magic drug. Look, it's just the Sardinians have no magic drugs. The Okinawans have no magic drugs. There's this combination of we have to try to adopt our lifestyle to make it work. That's going to be swimming upstream. And then what are the things we have to do to neutralize the fact that we do live in more polluted areas, that we are under more stress, that our food is devitalized, that we don't get enough movement? So that's where these nutrients kind of come in to try to create countermeasures, which I believe is going to be different for everyone in order to move that scale up from dying at 77 on 10 medications to hopefully getting people into their upper 80s relatively healthy right now. I know we all want exit velocity.
Right.
Exit velocity. Live to 150.
Yeah.
Okay. I'm all good.
Yeah.
I know our first step is we have a lot of groundwork we got to catch up on. Get your gluten. Yeah. Nobody puts enough emphasis on this. Get your glucose right. Get your insulin right. Get those bad actor lipids and oxidative compounds right. Make sure your kidneys are functioning. Have your hormones in balance. There's a lot of basic things people just are missing that I find what I've done over the years with my docs is we try to work hard at getting those big levers to be pulled in the right direction.
Yeah.
And lo and behold, people feel fantastic. Now, we've added peptides when we can, the ones we're allowed. We've added, over the years, bioidentical hormones. There's detox. Yeah, sometimes drugs, like the drugs that are anti-aging oriented. But it's you got to have a, it's not just this thing of going out and, hey, I just heard the Tibetan goji berries picked by monks. That's going to extend your leukocyte telomerase test.
Yeah. And that's going to be the big changer of your whole life when you're sitting down in the desk for 9 hours a day indoors.
Right. No, that's just it. So
isn't it funny how things just ebb and flow too? I feel like, early 2000s we're all, we think we're coming out with all of these scientific advancements, and whenever somebody says that the food is genetically modified or fortified, and we had this period where we're like, oh, that's got to be better, or we need to get rid of all meat and we need to eat only plants. And now we've kind of reached this peak. Everybody's gotten really unhealthy, and now we're like, actually, let's not put a bunch of chemicals on my face. People are starting to use beef tallow. Everybody's eating steak again. Like, it's this weird bell curve of, okay, nothing's working here, let's go back here, and then we'll get all the way down here. And people will be like, let's go back this way,
You know what's funny? I think that's accelerated because the amount of information that gets out, right? Back when I first started out, that was a whole different scenario.
Yeah.
Like back when I started out, you'd see that trend over pretty years. Hell, I think that stuff's happening now in 6 month, 1 year, blips, because people try it and they go, oh crap, this really didn't make me feel too good, and I just gained weight. I got to go this way, and I still laugh because everybody's looking for the magic way to eat, right? And my wife's a dietitian, 27 years in my clinics, but 30 years at it. And she just did a talk at A4M, and she dug into all these, all the blue ocean areas. There's no one diet. They're very different.
Yeah.
Other than maybe don't eat that almost meat that's high in a bunch of seed oils and chemicals, I mean, I never thought that was a good idea, but I think it's interesting that people keep insisting that there's going to be some magic potion. When you really looked at those areas, you saw that social context may have well been the most important piece of living longer.
Yeah, that's true. And it's funny how the social context of everything, now we're in a society where everything is so accessible and we're constantly seeing each other on social media, but at the same time, we're the most isolated we've ever been.
Right.
Nobody eats together. Nobody, we're kind of very, I guess, a little bit selfish in that way. We're all very focused on how we're going to live, how we're going to survive, how we're going to be the best that we can be. And in doing so, we've kind of isolated ourselves from one of the most important parts about living long is actually living, right?
Yeah.
Actually doing things with others.
Loving, connection, friendship, right?
Yeah.
Joy. Yeah. Well, it's funny. I mean, I just tell this story because I think this is the perfect example. When my father got a duodenal adenocarcinoma at 79 because he was a diabetic for 40 years, and diabetics have about 4 to 8 times higher risk, depending on which intestinal cancer you're looking at, of getting an intestinal cancer. He gets a Whipple surgery, poorly controlled 79-year-old diabetic. Whipple surgery at 79. Which, if you're listening, that's, like the lower portion of the stomach, all the duodenum, and the head of the pancreas. It's a
huge
bad surgery. It's good surgery, but longevity on that one's not so good, especially when you're 79. Well, we moved him into our home, and my son was just very young at that time. But we brought him in and made him a part of our home. He went everywhere with us, right? It wasn't like, hey, yeah, here you go. You got a bedroom to stay in. Be happy, right? But we introduced him to the treadmill. I did, and some dumbbells, and then Laura took care of diet. He lived 13 years.
Wow.
Which is, as a physician, that is unheard of.
That's insane.
And I believe it wasn't just the peptides or all the other stuff I was doing on him. I think he was engaged in going to my kid's baseball game, and man, he had a smile on his face, right? Yeah. And he was just happy to be there in the home with other people. I can't emphasize enough the points you made, that we are isolating ourselves, and that's tragic.
Yeah.
I learned that through him, actually, in that 13 years, is connect with people. It's a beautiful thing. Don't worry. Yeah, don't worry about it. Nobody's going to steal you.
Yeah. I've noticed that. I've noticed that time and time again, either in the inpatient rehab setting where I am now, or when I was an intern and I was doing, internal medicine and ICU, and we'd see that the people that tended to get a lot better, regardless of what they came in for, what surgery they had, what labs values they had, what their vitals were when they came in. This might be anecdotal just for me, but 100%, I saw the people that had something to go back to, were eager to go back to it, came in with a great attitude, had a crap day, was ready for the next one, wanted to kind of kick ass. And, a lot of people that, had faith in a higher power. There's so much power in kind of letting yourself off the hook and being selfless and wanting to go to your church and your community. Then you're fighting for something bigger than yourself.
I think that's a huge win. Probably the biggest thing I've learned over my life in this care. Kind of doing integrative care or regenerative, functional, holistic, whatever. Doing what I call good health care, being a part of that, it lends itself to that thought process.
Yeah.
Right? I love that, man.
That's awesome.
It's really important.
Well, let's back up a little bit. I am curious because we were talking about lab values before. We were talking about going kind of deep into different things. You mentioned testing people's mitochondria. How do you go about testing somebody's mitochondria? How do you figure out, obviously doing broad testing is always great for people. Doing a good comprehensive lab analysis is good for just about anybody. We'll kind of take a look under the hood. But when you really want to dive deep into how well you're producing and creating energy from the mitochondria, how do you actually go deep into that?
Well, I use MeScreen. That was developed at University of California, San Diego, Hemel Patel, university-based research, validated to punch biopsy. I mean, they've really have. It's a nice finger stick. Not a little pricey, right? It's not a cheap test, like $500 or something like that.
Right.
But it does show you where you're at with your mitochondria. It does give you a picture of reactive, how much oxidative stress, are you leaking oxygen, what's the efficiency of the mitochondria, right? And I think at one point I want everybody to do that. I don't have to start people doing that. I mean, it's obvious when people have insulin resistance, they have a blood sugar of 104 and an insulin of 13, and they've got high oxidized LDL, and their kidney function is low, and their magnesium status is really bad.
Yeah.
Their mitochondria aren't doing too good. Right? And
where do you start whenever you start to treat mitochondrial dysfunction? I know there's so many moving pieces that go into it, and you could get really into the weeds depending on exactly what somebody has. But just for your typical kind of day-to-day weekend warrior that comes in, hasn't been feeling great, are there some supplements that you tend to use for a lot of those people?
Well, a lot of times when they're not feeling great, it's due to allostatic load, right? The HPA axis is off, and now the brain's not telling the adrenal glands to do the right thing, and that starts to create problems in the nervous system. So, I mean, but if it boils down into the mitochondria, right? I think of, I mean, the obvious is CoQ10 and magnesium. Like a lot of people don't realize magnesium is so important. It's the number one nutrient deficiency that leads to insulin resistance in the U.S. And that is NIH published stuff. I mean, that's not, pulling it out of the hat.
Right.
So mag, super important for the mitochondria. CoQ10, super important for the mitochondria. PQQ, pyroquinolone quinone, is another mitochondrial catalyst. Benfotiamine, vitamin B1 is an important catalyst. Obviously, if you're young enough, B3 will work, but once you get over the age of 40, you lose the B3 salvage pathway, so then you got to figure another way to create NAD. And so that's something like nicotinamide riboside, so NR is really good for that. And that's a great start. You can think of some other things, but that's a really good start. And then if you get into kind of what used to be allowed on the peptide side, things like MOTC and SS31 were direct mitochondrial performers. Currently, something like a small molecule called OSO1 does a pretty good job of doing that. So I think, just those basic nutrients I mentioned, a lot of times people will feel better from that.
And is this something that you have to take forever, or is it one of those things where, if after you get a lot of lifestyle things in order, you take these supplements for a certain amount of time, can people tend to transition off of them and be in a better place than they were before?
I think magnesium is a forever thing.
Right.
I think the CoQ10, if you're on medications, is a forever thing. Levels of CoQ10 go down even with aging. I think, that's the one area I think is interesting. Your mitochondria aren't meant to be pushed like a workhorse.
Right.
Meaning that's one of the areas I think where and once again, no negativity to it, but one of the areas where biohacking has gone wrong is like just optimize all the time, right? Go, go, go. Let's push those mitochondria.
Yeah.
And that's proven out that might not be the best thing to do, that you need rejuvenation, right? So you need that mitochondrial renewal, which is written about, or mitochondrial biogenesis. We use them up, we make new ones, right?
Right.
So, but if you're always using them up, you can't keep up with making new ones, and that starts creating more redox issues in the cell, and you end up under more oxidative stress.
Okay.
So,
Yeah. Talking about dosing, I'm assuming magnesium glycinate, 200 to 500 milligrams of elemental magnesium a day-ish is a good place to start. What do you? I'm curious.
Great.
That and the CoQ10. I don't know anything about CoQ10 dosing, so I'd love to get your thoughts.
Glad to. Mag, I would probably start people with 500 milligrams elemental a day.
Okay.
2 to 3, 2 capsules twice a day, most of the time. Unless they got a loose stool, then you back it back.
Right.
Mainly because I've rarely seen somebody with a good red blood cell magnesium.
Right.
And I look at red blood cell magnesium as a more accurate way to determine true magnesium status. And you could get that at any lab, like, LabCorp Quest kind of thing. If you wanted to do it just for sleep, then 200 milligrams at bedtime would be fine. But then if somebody's training a lot, I dose them at somewhere between 5 to 10 milligrams per kilogram body weight of elemental magnesium.
Okay.
And that's worked real well for me over the last 30 years of doing that in sports performance.
Right.
So I do that. CoQ10, it matters what kind you get. There's crystalline, non-crystalline. You want to get the one that's a non-crystalline one. So what happens is CoQ10, even if it's in an oil, it'll start to recrystallize. You don't want that to happen. So there's crystalline-free CoQ10. Typically absorbs much better. You get about 7 times the amount of absorption out of that. I do a minimum of 100 milligrams a day. And then if you're on medications that deplete CoQ10, or if you have a neurodegenerative issue, well, then the doses start going up. If you're on multiple medications, it's probably 200 to 300 milligrams a day of CoQ10. Obviously, the studies on Parkinson's at 800 milligrams a day, showing some defined benefits in that situation. But typically 100 to 300 milligrams.
Okay, that's super useful. I didn't know that actually, so I appreciate you sharing that. When you're thinking about the essentials, at least in my head, I think of vitamin D. I guess I could make the case for CoQ10 at least later, maybe not when you're super young, but
yeah, right.
Vitamin D, I take 4,000 to 5,000 units a day, depending on where my levels are at. magnesium, omega-3s, B vitamins. I'm a huge fan of creatine. I know there's been a lot of studies about creatine, like the neuro effects, the cognitive effects of creatine coming out. Am I missing anything that you would consider as one of those kind of foundational, so many people are deficient in it, and maybe there's a gaping hole in what we're missing?
Well, I love aged garlic extract. So, for me, creatine's it's like an additive product, right? It's a nutraceutical. So I'd bring in aged garlic extract in that range just because it hits so many foundational things that people are struggling with today, right? Vascular problems, blood pressure's going up, they're making vulnerable plaque.
Yeah.
There's a lot of those types of issues. So I really like aged garlic extract. I think it's an important one. I mean, obviously, as you think through nutrients, it's all about if you're deficient. If you're a woman on oral contraceptives, you better be on a B vitamin, right? I mean,
Right.
like all this evidence finally came out about women on oral contraceptives being more depressed.
Yeah, and then that leads back to our conversation earlier.
Exactly. I was teaching that, again, not to say I told you so, but was teaching it at the university that there was already studies coming out showing this, that there were some women that because of the B6 deficiency that occurred from the oral contraceptive, that they couldn't make serotonin. And when they added back 100 milligrams of B6, only 100 milligrams of B6 for a period of time, their depression lifted.
Wow.
And so it was just basically a methylation error, right?
Wow.
But nobody picked up on that because a woman gets on an oral contraceptive 8 months later, she starts getting depressed. We're thinking, is it a bad relationship? What happened at work?
Yeah.
It's organic. It's just stress. It's adult ADD, whatever, right? It's just these things happen. No, she was on an oral contraceptive for the last 8 months, depleted her B vitamins. She's a poor methylator. Now she's not making serotonin or dopamine.
Wow.
And that now just got reiterated on this recent, like all the media you're seeing with the Women's Health Initiative and looking at hormones and how oral contraceptives are actually increasing a variety of risks. And the one on depression was, I think they were already publishing that it was an issue with B vitamins. And so sometimes you just laugh at it. So it's sad. It's really sad. But I think then it starts becoming, well, what are you in need of, right?
Yeah.
Even on the vitamin and mineral side, what are you in need of? What are you not getting in your diet?
Yeah.
So
Methylation's been a big topic of interest for a lot of people, especially kind of in this new, I guess, the biohacking regenerative medicine field. We see Gary Brecka all over the place talking about methylation, maybe overblowing it more than, it needs to be. But let's just say somebody's taking methylated B vitamins. They still think something's wrong. Their clinician thinks something's wrong. They want to go take a methylation test and see all of those kind of breakdown products and see where they're getting stopped in that whole system. How long do they need to be off of their supplements to actually get a good picture? So let's just say I'm, overloading methylfolate and B12, and then I go and get a methylation test 2 days later after I've only stopped for 2 days. Is that messing up the entire result?
probably, and I'd probably wait at least a week because you'll flush out a lot of those are water soluble. You'll flush those out. And, once again, even with methylation, we oversimplified it. Are you a 677T or a 1298C, MTHFR SNP? Well, there's a whole series of genes around those genes that are having haplotypic expression to kind of keep that in balance. So if your mood is bad or your homocysteine's elevated, good idea to probably get that checked. I mean, because I worry about, you saw the studies, high folate levels, not so good on colon cancer risk, right? If you're taking excess folate. So, I really think that, the methylation story is good. It's important that people understand it, but it's been oversimplified to just take a methylfolate supplement so they can be sold, which is, once again, I want them going to young docs like you that are really passionate and they're going to dig in.
Right. Well, I appreciate that. I am curious, talking about, I want to pick your brain too. I've heard you mention in the past, we were talking about cortisol earlier, right? And obviously I think for my age group, people that are constantly, grinding, they're in the early stages of their career, like me, have gone through medical school. Cortisol seems to be a big issue with people in that kind of stereotype. And in myself personally, you know, I got my 24-hour cortisol tested a few weeks ago and had a pretty low flattened curve. And, you know, I just reactively would say, oh, I have adrenal fatigue. But I've heard you talk in the past and say adrenal fatigue is really not a real thing. So I'm just curious, what's your thought process? Obviously, we all hear about high cortisol. Not many of us really stress the importance and the dangers of having low cortisol after that. You know, I'll leave it up to you to really explain it, because my thought process was that's adrenal fatigue from having high cortisol for too long. So I'm curious what you think.
Okay. So, yeah, because I've been in this conversation for a minute.
Yeah.
First of all, adrenal fatigue is a wonderful marketing term.
Right.
It is. It's good. It's good. I mean, I honestly, it grabs the consumer. It's just not medically accurate. If you look up adrenal fatigue, there isn't this is what happens. It's either hypocortisolism or nocturnal hypercortisolism, or it could be flattening of the cortisol curve. All of those are things that you read about in medical literature. So cortisol goes high when you're fighting a white tiger.
Right.
Cortisol goes low when you've been fighting a white tiger so long that you turn around and you look at it and go, what do you want?
Right.
You no longer have the shock. You no longer have the awe. Right. And I look, this is probably one of the biggest things that I've worked on over my 40 years is getting people to restore their cortisol curve. When you flatten your cortisol curve, whether it's flattened low or flattened high, what that means is you've retrained your brain to not produce it, and your brain is not producing that because it doesn't want to injure your brain, right? Because what happens is cortisol ends up hitting the hippocampus, and that creates dendritic retraction. And so basically what happens is it's trying to protect your hippocampus or your memory center, but initially that memory center will swell, they've shown, but then over time it contracts. And the other thought is when you're making a lot of cortisol, you stop your progenitor cells, basically your stem cells that make new neurons, you stop them from budding. So they don't go through that 4-stage, process of a glial-like stem cell to a progenitor cell to a new granule to a fully formed granule neuron that's dendritically pruned and hits the neural network, right? That stops when you've been on high cortisol. And unfortunately, what's been shown is even after the cortisol is high and has stopped, it does not return to creating those progenitor cells moving forward unless we correct for that by using things that like stimulate BDNF or brain-derived neurotropic factor, or we can think of decreasing glutamate and histamine and basically resetting the nervous system to allow that signal to occur. So when you flatten your cortisol curve, whether it's high or low, you're at a 333% increased risk of mood disorders, cardiometabolic disorders, and neurodegenerative disorders. And I think this is it's a tragedy because a lot of people are in that situation today. Well, 100%. A lot of your colleagues going through medical school already are on antidepressants.
I was a third or fourth year med student, and I remember going back into the classroom because those are, our clinical years. So I remember going back into the classroom for some meeting that we had, and somebody bringing out their bottle of Wellbutrin or Prozac or something, and me thinking like, oh wow, that's kind of wild. And then every single other person around me bringing out theirs and comparing what they were on and I saw it really early. I wasn't anybody that was like the top 5 in the class. I did very well, 50 percentile. But at the same time, I was going to the gym 5 days a week. I was getting outside. I was not studying any time past 9:30 or 10 because my brain shuts down at 5. I mean, that was just me. And
good for you.
My friends would be taking Adderall at 5 p.m. and then they'd be pulling all-nighters, and then they'd be getting on antidepressants probably because they're not sleeping. So it was this vicious pharmaceutical cycle that they were getting in, and I can't imagine where I would be. I mean, like I told you, I have this low cortisol curve, not necessarily flattened quite yet, but I can't imagine what I would be if I had gotten stuck in that cycle as well and was trying to work my way back now.
No, that's That's exactly right. I noticed that back, when I was teaching in medical school and, at University of Cincinnati is, 40% of the students were already on antidepressants. And,
Yeah.
And it's just getting harder because you have all this kind of instant information today that you have to absorb, right? So we're in this hyper absorption and we've got a primitive nervous system in a modern world, right? So that is problematic, and you have to restore that cortisol curve. It's interesting. This isn't new. So since the beginning of recorded medical history, the most valuable herb in every culture was an adaptogen. The herb that kept you being able to be resilient to stress. So whether it was ginseng, Manchurian ginseng, Siberian ginseng, ashwagandha,
Rhodiola.
schizandra, rhodiola, American ginseng, cordyceps, I can I can name 20 of them, right? But the point being is these were the most treasured extracts or plants because it kept people strong when they were living in very hard times. And today what happened is our adaptogens today are Xanax and Prozac. Well, and Ambien. I can't forget Ambien.
Right. Dang, that's kind of heavy when you put it like that. It's so true, though. I mean, that's our civilization's adaptogen, which is really sad.
Well, and it's post-adaptogen, really, right? Because adaptogens would have kept you strong and you never would have went down that path. That's the tragedy, truthfully, is that we gave up the thought of keeping people at a high level of resiliency and metabolic capacity. And instead we said, live all you want and we'll give you a pill. And I'm not saying the advancements. Some modern pills, like my father was alive. He lived 13 more years because of the wonders of modern medicine. It's all good with all that.
Yeah.
But in terms of living your life every day, we gave that up with modern medicine. Like I could show you at my University of Cincinnati, at the John Ray Lloyd had founded it. Lloyd Brothers Specific Medicines. He was the most world famous botanical extractor. Later became SmithKline French, which is a really old pharmaceutical company that then got bought again and again and again. So the point being is, I could go there, and all of these botanicals in the early 1900s were being utilized and deployed by pharmacies, by pharmaceutical companies, and we gave it up and just said, go ahead and gain weight. Go ahead and become diabetic. We got something good for you. Go ahead and become hypertensive.
Yeah. It's kind of interesting
sad.
when you start to play God and you think that we can create something better than the earth gave us.
Big believer in that, man. I tell you, I just see that that's the realignment that we really need, is that thought of I deserve to feel well.
Right.
And then what nutrients do I use? So, I mean, the adaptogens are a prime example that just, like you said, nobody thinks of that was civilizations relied on that in order to stay strong in very primitive times that were, I think, probably much harder than us because, I mean, they didn't have a golf cart to go to the end of their driveway and get their mail.
Yeah. Yeah, I mean, you could definitely make the parallel, too, between that argument and the fact that we're, outlawing things like psilocybin for mental health issues, but we're pushing a lot of these medications that we don't really know exactly what they do or what the consequences of them are.
Well, I mean, that is a whole discussion on its own when you start talking about psych drugs and efficacy now.
Yeah.
That's tragedy because, once again, we don't take into account the gut-brain axis and the signaling of the enteric nervous system and what's going on, and instead we're trying to use a drug. And a great example of this is people that develop adult ADD. Adult ADD. I could just go all through university. I was fine. I could remember. I developed this. No, you developed a loss of neurotransmitter vigilance because of your stressful life or whatever else you did, or environmental burden, whatever it was. Something caused it, and we don't. And so then they get on that medication, and 4 years later they're told, oh, you know what? You need that antidepressant to balance out all that dopamine and adrenaline you've been kicking from that Adderall.
Yeah.
And once again, sometimes that drug cocktail works wonderful for people for a while. But we don't look at the progression.
Yeah.
And when you asked me what really was the thing that I learned over 40 years, it is watching people's chemistries progress, either towards a progressive vicariation of problems or being able to regress them back, right? And it's that flow, that stream that you watch with people. And I think that was the biggest thing over the years that I've been really just, absolutely fascinating to me.
Yeah, I agree. Jim, I can't let you go without asking you about this because I'm such a fan of this book and I'm halfway through and I'm fascinated with it. And I know that peptides are so big. And so the last topic I really want to touch on is this.
Let's go.
There are a lot of peptides in this book and a lot of protocols. And I don't even know how many there are on the market anymore. So my question is, everybody is so excited about peptides, and I get questions all the time. That's half the reason why I got this book is because I can't answer 90% of these questions because I don't know enough about it yet.
Sure.
Where do you think we're going here? I mean, do you think that this new leaf with the FDA, I mean, I know we haven't seen a lot of what was promised at first, but do you think that there is going to be some sort of push towards the peptides, the stem cells, the exosome world? Or are we just always going to be playing, cops and robbers with this whole game of what is available at what time?
Depends on what happens in the long term administratively, for one, right? I would say that peptides stand a good chance of the ones that have kind of been out will probably surface again. I think we need some standard that says, hey, this one's okay to try. Like, there should be some vetting or check the box of, oh, wow, yeah, there was an animal study that showed there's no toxicology, right?
Yeah.
Now, obviously, FDA has published that said peptides under 8 amino acids exhibit very limited risk of toxicity of any kind, especially liver and kidney toxicity. They wrote that. So the shorter peptides like KPV, actually, glutathione's a peptide. Very low risk. The larger molecules like the terzepatides and those kind of things, yeah, they carry a little more weight. I think that, like anything, new ideas don't get accepted, old people die. Right? I think we'll see a progression of being allowed to use some of it. I welcome that we have more standards. Obviously, there's a lot of warning letters going out right now to the research labs that are not for human use. And I think that that's good. I mean, I'm after my clinical pharmacy degree and biology degree and diplomat and all my stuff I've studied, I'm still a pharmacist at heart. Right. And I believe in safety, and I really do. And I think we need to make sure we don't forget about safety.
Right.
I think peptides, though, if I look at the last 10 years of doing a lot of work with a lot of different folks, I think it's one of the most significant new tools in the toolbox that I've seen. It's that important.
When you say new, how long have you been using peptides in your practice, or at least been interested in peptides?
Well, at least from us, if you don't include insulin, right? Because insulin is a peptide.
And before, other than insulin and GLP-1s?
Yeah. I would say 10 years.
Okay.
Maybe a little more.
Yeah. So that's definitely on the forefront of the excitement.
Yeah, I got at it kind of quick. I mean, I had a good mentor on it, so I got at it kind of quick.
Was that the bodybuilder in you that got interested in it?
Oh, I was way past bodybuilding after that, but I think probably the gestalt of being a bodybuilder,
right?
Because obviously that a lot of this stuff populated out of the bodybuilding culture. But I would say that one of the biggest dangers of peptides, because it all sounds good when you're reading it, you're halfway through, you probably want every one of them. I want to do that. I want to do that.
I want to do great. That. Yeah.
Right?
Yeah.
And I think that's what I saw that I wasn't a fan of early on is, people injecting themselves with 10 different peptides 3 times a day. Look, if it's for saving your life or you have this drastic condition and that's the protocol, I get it. But it's about, like, what do you really need now? And I think there's a seasonality to it, just like you had alluded to on the mitochondrial side. Do we push? I think with peptides, there's some seasonality to it that you want to think of. You know, am I going for longevity, reestablishing normalcy in my master slave clock, my suprachiasmatic nucleus? Am I using epitalon and Vylon for that? I like those conversations. I think that makes sense. I just think, once again, if you're doing a bunch of peptides, you're injecting yourself and you're doing hormones and your blood sugar's still 105 and your insulin's still 18 and you still have a bunch of bad numbers because you're not willing to change your lifestyle.
Yeah.
I wouldn't spend all that money on all that stuff. I'd start working on changing your lifestyle.
100%.
And use motivational things. Like right now, I've got my Ultra Human ring on, my Whoop 5 on.
There we go.
And my Apple Watch on, because I'm always comparing. And I'm always comparing them, man. I can't, and honestly, I'm comparing them because, one, my role was the Chief Science Officer with Lifetime.
Yeah.
I want to understand those things, but I still think there's just so much variability on all that stuff, that it's interesting.
And there's so many of them, man. Maybe down the road after I finish this book and take my notes, we can do another podcast someday where we kind of go through a couple of them one by one.
Let's do that.
Yeah, that'd be fun.
That. And let's correct that cortisol flattening.
Yeah, no, that's step number one right now. So I'd appreciate some input after we get off the podcast.
Sounds good.
All right, man. Well, it's been a pleasure, Jim. Seriously, I hope we do this again, and thank you for coming on.
Wow, so much fun. Thanks, Clay. Really appreciate it.
All right, man.